And welcome to everyone who has joined us online. My name is Annette. I work at the Clinical Center Department of Bioethics and at Fogarty International Center. And it's my pleasure to welcome Dr. Matthew Harris today for this talk. This was originally going to be a hybrid event, and it's entirely my fault or my son's fault, who got sick, that I couldn't be on campus today, that we switched to online. So thank you to everyone for being flexible. So Matthew Harris is a clinical senior lecturer in public health medicine and an honorary consultant in public health medicine, as well as director of postgraduate taught courses in the School of Public Health at Imperial College London. And he is the theme lead for innovation and evaluation in the National Institute of Health Research, Northwest London Applied Research Collaborative in the UK. He's worked in many places and lived in many places, namely in Brazil as a family doctor, in Ethiopia, working for the WHO in immunization programs, and in Mozambique as an HIV technical advisor. And he served for 2 years as a global health policy advisor to the UK government. And Matthew wrote a very interesting book that he's here to present today on decolonizing global health, and I'm very excited that he's going to share, some key insights from this book with us. The connection to Fogarty's work is that Matthew has participated in the working group convened by Linda Kupfer, who is also here, and on reciprocal innovation in global health. If everyone could mute their could everyone please mute themselves? Yeah, all right. So I just muted this person, I think. And so Matthew has worked on this working group led by Linda Kupfer, and he is part of a group that I'm also part of, looking at the ethical, legal and regulatory considerations on reciprocal innovation in global health. So really excited, Matthew, for you to be here. Thank you so much. And yeah, please share your insights.
Well, Annette, thank you so much for the opportunity. I have to say, it is a shame, of course, that we can't do this in person. I had some free copies of books to hand out to those that were prepared to read it. But don't ever apologize for putting family first. It's exactly how it should be. But can I thank you for this opportunity? It's wonderful to be here in Washington, and even though we're doing this online, it's wonderful to be in this great city. And I'm excited to be able to share some insights from this book. I hope it resonates. I know that Fogarty and many organizations within NIH are grappling with some of these issues. So I'm going to talk for about half an hour or so, which hopefully will give a little bit of time for some Q&A, and maybe even to get into some of the issues in a bit more depth. I'm going to present in sort of two stages, I think. The first is to present some of the opportunities that I think are really important and emerging to learn from low-income countries. This isn't a new phenomenon, of course. The importance of learning from low-income countries and the opportunity to do so has been around for years. But I think increasingly so, we're talking about this in this space because in high-income countries such as here in the US and in the UK, there's really a growing need, I think, a growing imperative to do more with less. And so we're better to draw inspiration than from countries that have been doing that for a lot longer. So I'm going to start by drawing down a few interesting frugal healthcare innovations, and then I'm going to pivot and talk about why it's been challenging to adopt some of those innovations into the NHS at least. And I think there may be some parallels as well with perhaps the systems here in the US. It would be interesting to explore whether or not some of those challenges exist as well. So let me just start with a few examples. The classic one, and some of you may already be familiar with some of this content, particularly this particular device. It's called the GE MAC 400, and it's an ECG machine. So it's a heart monitor, essentially, an electrocardiogram. General Electric challenged their Indian subsidiary to come up with this frugal healthcare alternative to what is otherwise very expensive ECG monitors that we usually have in secondary and tertiary care that can cost at least $5,000 or more. the reason for that was because access to this sort of technology in that context was quite challenging. The equipment wasn't available in some settings, and they wanted to see if they could develop a device that was actually cheaper, more rugged, lightweight, that doctors could put in their satchel and take out into the rural communities in order to improve access to ECG monitoring, to heart monitoring. And they came up with this device, which actually was inspired by some of the machines that bus conductors used to use in London in the old days, little machines that spat out tickets if you put the money in the machine. So it was drew down inspiration from that, and essentially provides an ECG of exactly the same sort of qualities you'd expect from a more sophisticated device, but at 1/10 of the price. And interestingly, GE is now marketing this device in the US market, and is actually starting to disrupt the ECG market here, even in this country. So this has been called a reverse innovation, and I'm going to dig into a little bit about what we mean by reverse innovation, some of the issues with that terminology. But this was first discussed in the Harvard Business Review in 2009, and the reverse bit meaning coming from India back into the United States. Another good example of that actually has been happening in Baltimore, not far from here, of course, is this example of an orthopedic drill device. Ordinarily, some of you might be aware that in orthopedic surgery, you need to have a drill in order to drill holes, to fix a K-wire, to fix a fracture, and so on. And the devices, certainly the ones that we use in the UK, in the NHS, are really expensive. They're about £30,000 each for the device that you see on the top. They're called Stryker drills. And that's because you can put them in an oven and bake them so that they become sterile and therefore suitable for an operating theatre environment. But in Malawi, in Uganda, this sort of equipment wasn't available. And orthopedic surgeons then improvised, and they took a regular hardware drill, such as the one you can see in the bottom. It's a DeWalt drill. You would use it to put up shelves in your home. But they made it fit for purpose, made for an operating theatre environment, by creating a sterilizable, reusable cloth bag into which that drill can be inserted. And then it becomes essentially a sterile device. There's no such thing as sort of kind of sterile. It's either sterile or not sterile. And this is a sterile device when used properly. It turns out that the total cost of using this equipment is really a fraction of the more sophisticated technologies we use in the NHS. And we calculated that actually could save hundreds of thousands of pounds a year in each hospital across the country if we use this device. And studies have shown in Baltimore that actually there are no difference in outcomes in terms of infection rates comparing this device to the more sophisticated technology. Let me just run through a couple more examples of the same sort of nature. In inguinal hernia repairs, some of you may appreciate that you have to use a hernia mesh. It's made of a polyethylene material. It's got pores in it. It's actually very expensive. It's about £100 in the UK for each device. It comes pre-cut, pre-sterilized. It's single use only. It turns out that actually it's made of exactly the same material that mosquito nets are made of, give or take a few differences in the biomechanical properties. It's exactly the same material. So in India, where it began and spreading throughout sub-Saharan Africa, in countries like Rwanda, for example, they used mosquito nets to treat inguinal hernias operatively. If you consider a mosquito net costing about $10 for an entire one, you could cut out thousands of appropriately sized portions for individual use. And as long as you sterilize it, clinical trials comparing commercial mesh with the mosquito net mesh actually shows no difference in outcomes, infection rates, relapse rates, adverse events, and it costs a fraction of the commercial material. Here's another example. It's called Saiba's method, and this one is in the area of postpartum hemorrhage, a very unfortunate situation where it often leads to an obstetric emergency and surgical intervention. But just prior to that, we use what's called balloon tamponade devices. So this picture shows 4 balloon tamponade devices on the left-hand side of the image that are commercially made. They're made specifically for this purpose, and each one will cost several £100s in the NHS at least. Now, Saiba's method is a technique that originated in Bangladesh, where you just tie a condom onto the end of a urinary catheter, both of which are in plentiful supply and very, very cheap, as you can see in the right-hand side of this image. And actually, clinical trials and systematic reviews have actually demonstrated that there are no difference in outcomes in terms of mortality or
you come sit behind me.
using this device compared to the commercial devices. And then finally, my example comes from the Amazon. This is a Brazilian example in the case of second and third degree burn treatment, where ordinarily, at least in the NHS, for second degree burns, we would use either porcine or cadaveric skin grafts, which are actually very expensive to do. In the Amazon, tilapia fish, I think some of you may even eat it here, is plentiful, abundant, and very, very cheap. And the skin actually contains an awful lot of collagen of variety. And they've been using it in phase 3 trials and showing that actually it leads to reduced infection rates, hospital stay and pain, and very, very rapid re-epithelialization. It doesn't require even bandage changing, and only $11 for a course of treatment. So what we're talking about here, born out of necessity, perhaps, improvisation, ingenuity, using the resources available around them, repurposing devices from one application to another. Frugal healthcare innovation, which predominantly arises from low-income countries, but not exclusively, is a really interesting opportunity because you do more with less for more people, improves access to care where there might not be access, technologies that might not be affordable become more affordable, or can be used in more remote settings and so on. Sometimes we see innovations such as these that don't require electricity supply. They may be solar powered, etc. There are many, many other examples that we could go into, but we don't have time to today. But there are challenges in adopting these sorts of innovations. And so in my book, I use texts that we see all around us to try and understand and surface some of the hidden assumptions or meanings that we hold in society, particularly in the UK, because my book is predominantly for a UK audience, but I think applicable to most of the West as well. Some hidden assumptions that we can identify in the texts that we read and try and surface some of those assumptions in order to get at them and interrogate them and reflect on them. And there are techniques I talk about, such as exnomination, structured absences, and the commutation test. So exnomination is essentially where something is just a given. It doesn't even require explanation. And sometimes we have to look out for these things. So in the UK, for example, our police officers are called police constables. And that is the norm. They're called police constables. When they are female police constables, they are called women police constables, WPCs. So it doesn't require, we don't call them male police constables, we just call them police constables, whereas female ones happen to be called women police constables. They have to be identified as different. So in this case, exnomination is an example where it's almost an unsaid, taken for granted norm. You don't need to genderize police constables when they're men. Similar example is around structured absences. If you look at almost any American movie, to be honest, most of the villains are always British. Why is that? You never see villains that are, I don't take that personally, it's just one of those things, and probably rooted in historical, events of the past, of course. It makes sense in terms of collective psyche. But you wouldn't really hear, you don't see many films where the villains are Italian or Swedish in American movies. Now, why is that? And that's what we call a structured absence. It's an absence of a phenomenon that you only really notice when you think about it. And another example is a commutation test, where you flip or reverse the valence, we might call it, of a particular phenomenon. So many of you will be familiar with the Sopranos TV series. How do we feel about the main actor in the main role in that series being called Tanya Soprano? There's something about it having to be a male lead of a mafia organization that tells us about what we understand about structured violence within societies. So applying some of these techniques, I looked at some significant policy reports in the UK, but also around in the US, as it happens, which I'll come to. And one of the things I noticed is that one of the challenges in adopting innovations from low-income countries into our country is that we don't look to those countries. Significant policy reports predominantly focus on a central core of countries to whom we compare ourselves with. So this is an example from a very significant report that was published about 20 years ago called the Wanless Report, which mentions only a handful of countries in this report to justify some of the conclusions that it made, and these were France, Germany, Netherlands, Sweden, Australia, Canada, and New Zealand. doesn't even explain why those countries are selected, apart from for one reason, which if you dig deeply, you can only find this one instance. And it's explained as saying, well, these countries we look to because they have broadly similar levels of income per head of population. But actually, so does the Faroe Islands and Greenland and Guam and Puerto Rico. So why weren't they, based on that rationale and that logic that was given, why weren't those countries included? Let's look at the Commonwealth Fund. I'm a big fan of the Commonwealth Fund. I was lucky enough to receive a Harkness Fellowship from the Commonwealth Fund and spent a year at New York University because of the Commonwealth Fund. But I happen to also notice that the reports that they produce about international health system comparisons also predominantly focus on Australia and Canada and France and Germany and the Netherlands and New Zealand, the same sorts of countries. They give very few reasons in their methodologies as to why that is, apart from for two instances. The first is the dollar spent on health per capita, which you can see at the bottom of the screen. But Cuba spends actually more or less the same order of magnitude of spending on health per capita. And another reason was the percentage of GDP spent per capita on health. Not shown here, but in the report, was in the region of 8 to 10%. US is obviously an outlier in this instance and always is. But there are many other countries that happen to spend the same percentage GDP per capita on health, such as Uruguay and Suriname and South Africa and Sierra Leone. But what would it read like? How would it feel to us if a report such as this actually chose those countries to compare the UK to? Another example, my final example in this instance, is around the NHS long-term plan, which just came out a couple of years ago. It's exactly the same countries mentioned, no reason given apart from in one instance, Germany was looked at as a comparator to the UK, looking at leg amputation rates, because they noticed that Germany had twice the rate of leg amputations as the UK, but then so does KwaZulu-Natal. So why wasn't KwaZulu-Natal identified as a country to compare to in that instance? So these are phenomena that I think you only really notice when you're actually looking for them. We did a little piece of research a couple of years ago asking what are the issues in adopting innovations from low-income countries into the US, as it happens. And we found comments like these. Well, it makes sense to identify innovations from Canada because Canadians look more similar to the US. There are many more Americans have been. You could picture a school in Canada being like a school in the US. And so in our minds, we create these logics, but in actual fact, they're not based on any rational fact at all. So here's a piece of work that came out from Irene Papanikolaou in JAMA a few years ago, and this wasn't the focus of her research at all. They simply described structural characteristics around the healthcare workforce and population demographics and burden of disease of a number of different countries around the world. The first thing to note is that the countries that they chose to compare each other to are the same countries I've already discussed. So the same sorts of, we've got Australia and France and the United States and Canada. But the other really important thing I think that they found, which they don't actually specifically focus on, is that there is no way to actually identify how similar one country is to another. You might find, for example, that Sweden and Germany are very similar in terms of overall physicians for every 1,000 population, but very different on another metric. And this isn't the only area that they looked at. This is looking at healthcare spending and it's looking at population health. I think it's very hard to discern any particular trend that one country is very similar to another. We're all as different to each other, equally different to each other. No context is the same. So when we actually identify a league of nations, let's call them, to whom we think we have some sort of something in common, really that's a logic that's rooted in something else. And that might be something to do with this core and periphery in global health. This is a really interesting piece of work that came out in Scientific Reports about 10 years ago, looking at the consumption of research globally. And as you can see here, there's a clear skew between what we might call the global north and the global south. So countries such as the United States and the UK and many European countries are heavily represented in terms of the amount of research that is consumed globally as represented by citation counts. And this is clearly going to be a function of the amount of research that's produced, perhaps even the quality of the research, But also it's going to be a function of where that research was published, the fact that it was published in English, which is the universal scientific language. So what we start to see here is that some countries that are better resourced will be able to produce more research and get them into high impact factor journals, which would therefore lead to higher citation counts. But this is a skewed and highly inequitable knowledge ecosystem around the world. And the end result of this is that really what we're seeing here is that some regions can be considered to be a core or part of the mainstream, and other regions essentially invisible in terms of the amount of research that we choose to consume from there. Sometimes because they're just not available, and other times because we might not be paying attention. Essentially what we're looking at here is an echo chamber. Yeah. And this is reinforced time and time and time again by representations and stereotypes in a variety of different channels, whether it's in the mass media or in other means. And we're just starting to now, what I'm trying to drill down to now is like how much of this is structuring the way in which we look at healthcare innovation more generally. I don't think anything represents this issue more clearly and simply and elegantly as the term reverse innovation. Annette and Linda and many of my colleagues from the NIH, we've discussed this at length, that the problems with this terminology is that it really is pejorative. It suggests, doesn't it, that innovation normally flows in one direction, from the global north to the global south. So when we're talking about adopting innovations from low-income countries, that's in reverse. Now, I think there's some value in maintaining this terminology because it helps us think about the importance of reimagining this dynamic, but it also, if we're careless about it, it just reinforces and perpetuates the same sort of issue. So we have to really, I think, be intentional about using these sorts of language in the right sort of way. Okay, let me give you a few personal examples that have been impacting me and actually motivated me to write this book in the first place. As Annette, you mentioned, I was a GP in Northeast Brazil, extremely impoverished rural community. I was a single-handed GP with 5,000 people in my community, but I worked with 4 amazing community health workers. And as some of you might be aware, but Brazil has the largest community health worker system in the world. It's been going for 30 years. I was there 20 years ago, just as it was getting going. And it's now scaled to almost the entire country. So there's a 275,000 community health workers. I know here in the US, you have about 90,000, but in Brazil, they are literally the system. They are part of the primary care system. You cannot move in primary care without having your community health worker first know how things are going and supporting you. And when coming back from Brazil, I immediately saw what the opportunities were for us to bring some of that learning back into the UK. The local, universal, proactive outreach that community health workers provide in Brazil, with only 150 houses each in their list, but in a geographical region that's very well defined, would address widening entrenched health inequalities and unequal access and experience of health and social care in the UK. The fact that these were local lay people trained and paid, rapidly deployed and easy to scale, addresses our workforce crisis and long-term training problem around recruitment and retention. The fact that they deliver a comprehensive array of health promotion and health and social care support across the life course, any age, any group, any ethnicity, any background. If you live in the house that they're responsible for, they will look out for you. Means that they're able to also identify the social factors that determine 80% of poor health outcomes that we see at the sharp end. But also the fact that they were integrated into the primary care team, not operating as a parallel system, suggests to me that they would tackle and address our current problem in the NHS around fragmentation of care and really lots of difficulty that people have in navigating the system, which tends to be based on very vertical specialist orientation of health services. But in that journey, in that 20 years, I came up against time and time and time again this sense of us versus them, okay, that I think I was trying to get at in the previous slides. What could we possibly learn from a developing country? Does it even have a health system? So it was less about, well, let's have a look at objectively what that community health worker role is and how it might fit. Something that I could see very clearly, both sides of the coin. The Brazilian system, having worked there for 4 years, and the UK system, re-immersing myself back into it. But my colleagues, senior colleagues across the health system, even chief executives of major central organizations, just couldn't get over the fact that this was a role, this was an innovation that was coming from a country they weren't used to paying attention to. So we can see something like that time and time again in many of the innovations that I've just described. This comes from a New England Journal of Medicine paper that was actually a randomized clinical trial, individually randomized controlled trial between the commercial mesh used for hernia repair and mosquito net mesh. And their conclusions were very clear that the clinical outcomes from both of those technologies in a randomized control, very robust study were completely the same. But their conclusions were that this supports the use of the mosquito net mesh in resource scarce settings. But I asked I think what's an important question. If you've got a device that actually is 10,000 times cheaper than what you're currently using with equal outcomes, then why aren't you using it in all settings? Why only resource settings, resource poor settings? There's something in there about it's a cheap device, therefore it's for poor countries. There's something in there about that, I think. Here's another example, and this time it comes from the Brazilian researchers themselves. Same situation around Nile tilapia fish skin benefiting treatment for severe burns, but their recommendations were that it should only be used for resource poor settings. So I think this directionality, this us versus them, kind of goes in both ways. Here's another example, again around the Sahiba's device, suggesting it's a much more affordable alternative to expensive technologies, therefore it should be used in low resource countries. But what I think is also important here, just want to make a quick point, is they don't refer to it as Sahiba's method, which is what it was called. That it was first appeared in the literature as Sahiba's method. Dr. Sahiba Akhtar, who discovered this ingenious improvisation, actually has tried to patent this method as Sahiba's method. But it's referred to as a condom catheter device, not Sahiba's method. I just want to draw your attention to that, because in surgery, we have a tendency to want to give eponymous names to many different surgical either techniques or devices that you may be familiar with. So Arthur Blakemore gave his name to the Sainstack and Blakemore tube. Frederick Foley gave his name to the Foley catheter. Peter Chamberlain gave his name to the Chamberlain forceps. Andre Levitt gave his name to the Levitt forceps. Christian Keelan gave his name to the Keelan forceps. The Pfannenstiel incision you might be familiar with. But when it comes to an ingenious improvisation coming from a Bangladeshi obstetrician, we somehow erase the attribution. Somehow that is erased. Interesting just to observe that again through textual analysis. So let's also, the question here is, well, this might be anecdotal. Can you really corroborate this? Where's the evidence that we've got these sorts of unconscious biases against low-income countries? And I just want to draw your attention to a piece of research that we did back in 2017 that got published in Health Affairs, where we invited English clinicians to rate research abstracts. And these were the 4 abstracts. I mean, just the titles here, of course. The actual abstracts were your standard PubMed abstracts that you'll all be familiar with. But what we did was we fictionalized the author affiliation of these abstracts to either a high-income country or low-income country. So high-income country in red and low-income country in blue in this instance. And then we asked them 3 questions. What do you think was the strength of the evidence in the abstract that you've just read? Was it relevant to you? To what extent is it relevant to you? And to what extent, what's the likelihood that you will recommend this abstract to a colleague? So 3 fairly straightforward questions. And then we invited the same clinicians to rate the same abstracts again a second time, 1 month later. But this time, where the author affiliation was a high-income country, we converted it to a low-income country. And whereas a low-income country, we converted it to a high-income country. We asked them exactly the same questions a month later to see if their answers had changed. Now, it shouldn't have changed. It was the same person rating the same abstract, and we're comparing their responses to themselves, not to other people. But what we found when we looked at the differences is that when they were rating the abstracts listed as coming from a high-income country, they gave significantly higher ratings on all of these measures. Now, if this was a clinical intervention, a pharmaceutical trial or a pill, these results would either have to stop the trial early or make everyone take the pill. These were significant findings in terms of statistical significance. They weren't significant in terms of the magnitude of differences necessarily, but these are essentially what I would call microaggressions towards low-income country research, that when at pace and scale, when you think about all of the research that's consumed globally all of the time, from all settings, these begin to make a big difference in how we consume research. My book then talks about what are the reasons for all of this. And I dig into, in several chapters, some of the historical trajectories that we've undergone in Europe and in modern medicine to explore what we call the colonial underpinnings to this phenomenon. And it's all to do with, as Walter Mignolo and Catherine Walsh describe beautifully in their text on decoloniality. It's all to do with the colonial matrix of power, which is very difficult for us to extricate ourselves from, because it's all about how we developed to codify knowledge and control knowledge. We're talking about how universities have developed, how libraries have developed, how museums have developed, and their role in history in deciding what gets codified, what gets consumed. I don't have time to go into all of these aspects today, but the book does. And so I invite you to read that, because it all goes back to the medieval times around how the thinking began during the Enlightenment and Renaissance periods about laws of contradiction, that binary oppositions became a thing. So therefore we could enunciate people as either being traditional or modern or primitive or advanced. This idea of totalities is not an ontological truth. It is a construction, a social construction that emerged during the European Renaissance of the 15th century. And then this became reinforced at the same time as we were developing our modern medical institutions. This took place at the same time as colonial expansion. The scientific method is intimately related to colonial expansion. In fact, epidemiology is intimately related to colonial expansion. When you think about missionary medicine, plague surveillance, disease eradication efforts, they're intimately intertwined with with my country, British Empire, and French Empire, and Belgium, and others, in being able to control and subvert other nations. We began to see nature as a material object, something that could be, and disease as a biological dysfunction. And that has really formed an underpinning of our modern medicine. But it's really Victor Ray who makes the connection between this history and its impact on our thinking, and how we treat institutions from, let's say, the global south. And he talks about this as racialized organizations, which for me feels like a really important connection. He argues that organization theory has largely developed in a race-neutral way. And equally, the study of race and racism is absent of any organizational theory. We don't really consider how organizations play out and what their role in racism. But actually, organizations have important roles to play in the way their hierarchies and power processes can perpetuate racism and other things, such as anti-discrimination policies that aren't enforced. But equally, and this is the important one, I think, is that organizations can be perceived as racial entities. He gives the example of thinking about black banks or ethnic restaurants. We attribute we racialize organizations in this way. And it's why Nature, the preeminent international medical journal, recently, just last year, acknowledged and recognized itself as what it called a white organization. Now, they're not, of course, saying that everybody in their organization is white, and they're not talking about the color of the buildings where they operate in. They're talking about the fact that it's a mainstream entity. It's part of an orthodoxy that is at the core of a global knowledge episteme. And if you can think about Nature as a white organization, then you can think about, I'm just going to pick one, the University of Addis Ababa as a black organization, not in the mainstream, not in the core, not part of the dominant episteme. And that's a problem because it interferes with the way in which we perceive the products from that organization. Moving forward, and Annette, these are just my last few slides, if you'll permit me, is that okay? There are three ways that Andreotti explains what we can do about this. They talk about soft reform interventions, radical reform interventions, and beyond reform interventions. So soft reform interventions, an example like this, that actually comes from my organization, Imperial College. I've been leading on a tool that converts reading lists into which we use to teach postgraduate, undergraduate students, the reading list is converted into machine readable code, where you can then immediately at pace develop a cartogram that shows where you're teaching from. It's very hard to do that without this tool, because you can't look at hundreds of different citations and know immediately where you're teaching from, because all the institutions you'd have to go into each paper and work it out. So this does this automatically. And so what we're seeing here is just an example that on our Masters in Public Health program, that predominantly the y-axis means the level of development of the countries from where that research came from. Predominantly modules, which are all color-coded here over 2 time periods, teach from rich countries. That's what this is saying. And what it does is it enables module leaders and educators to start to interrogate what's with that. You know, is that a problem? Why is that? Does it surprise me? Should I change it? Begins to invite interrogation and surface some of those things. But this is an example of soft reform. All it's really doing is inviting educators to consider introducing more knowledge from other settings, but it doesn't change the rules of the game. It's inviting more knowledge into the mainstream. It's inviting more knowledge into what we're doing already. And that's why it's an example of a soft reform. It's a good starting point, but it's not going to change things. Another really exciting example here in the United States is that the White House actually just last year made a decree that all indigenous knowledge ought to be included in federal research policy and decision making. So again, a really important advance, because it's becoming, policymakers becoming more open to wider sources of information and acknowledging the heritage and ingenuity and wisdom of other populations and groups, but it's not changing the rules of the game. Okay, so it's still another example of soft reform. Colleagues on this call, Annette and Linda and others, doing some really important work around the idea of reciprocity, and instead of calling it reverse innovation, reciprocal innovation, where we improve our mutual learning processes and dynamics between partner countries when we're talking about the US working with low-income countries, so that both countries stand to benefit, not just low-income country partners learning from the US or the UK, for example. And there are many excellent examples of this happening in the US, such as the Global Learning to Advance Health Equity Network at the University of Maryland, the Robert Wood Johnson Foundation, and the fact that there are now grant applications that incorporate principles of reciprocal innovation into their application processes. Another example is work that we did in the UK, working for an organization called the Tropical Health Education Trust, where we provide an innovation toolkit to help NHS colleagues who are looking to work overseas interrogate some of their unconscious biases, to construct those partnerships with a healthier, more equitable dynamic, where they go in not just wanting to change things locally, but also asking what are the problems that we share and what are the problems that you could also help with us. So starting to move now away from soft reform, a little bit more into radical reform strategies, because we're starting to question the rules of the game a little bit. But it's only really when we get into addressing the colonial underpinnings of the way in which we teach medical students and train our doctors that we're actually going to begin to do the radical reform that Andreotti and others have invited us to consider. This is where we don't just consider what we're teaching or where we're teaching from, but how we even make those decisions in the first place. It's asking at a very deep and reflexive level, what are the alternative health systems that we can be addressing? How does evidence-based medicine even work? Why do we even have that as a concept? How can we critically reflect on everything that we do to give everybody a chance to actually rewrite the rules of the game? And just recently, just last week, I think there was a paper that came out talking about how important this work is to do, but not just in high-income countries. You have to do it also in low-income countries. The decoloniality journey needs to go in both directions. I'm very pleased to say that despite the just my last 2 slides, I think, Annette, I'm very pleased to say that despite the 20-year journey and despite it falling on deaf ears for many, many years, we've been now piloting the Brazilian system of community health workers in London. It's expanded extraordinarily. We now have it in, I think, nearly 15 different localities across England. But also it was mentioned in a recent policy report, the Fuller Stockdate report in 2022, shortlisted for a number of awards, and even debated in our House of Lords by the Bishop of London. I'm for me personally, that's hugely gratifying because I've had an impact in bringing some important learning back into the NHS. It's just a shame that it took 20 years. Had we been talking about Brazil as a potential learning source 20 years ago and addressing coloniality, maybe we would have had an army of community health workers in place by now to support us during what was a very difficult COVID time. I think this is my final slide. So just to talk about the beyond reform opportunity that Andrew talked about. This is all about disinvesting in the current unsustainable world, creating new worlds, learning from, giving us permission to make different mistakes and create hope for other systems. There's a very interesting example of that in the journal Decolonial Subversions by my colleague Romina Strati in SOAS in London, where it's a peer-reviewed journal, but it doesn't have a language barrier, for example. So it invites submissions from any culture in any language, removing all barriers and obstacles to publish for free in this journal. I've never seen anything like that before. For me, that feels like a good example of how to create new knowledge in a decolonial way. Finally, I couldn't do this without obviously pitching and plugging the book. You would have had some free copies had we done this in person, but it's called Decolonizing Healthcare Innovation. It's available from Routledge and Amazon and all good bookstores. And if you type in this code EFLO2, I think you get a 20% discount. So I invite you to do that. And please, if you do get it and you do enjoy it, do let me know or feedback to me what you think. If you didn't enjoy it, I don't want to hear from you.
Excellent. Thank you so much, Matthew. Also, for staying well in time, because we did start about 10 minutes late, and we have about 17 minutes now for questions and answers. So those who are, who have questions, please raise your hand or to speak up or type questions into the chat. I'm also monitoring the chat. So not seeing any at the moment. Oh, there is. Perfect. All right. So because Matthew and I had a chance to talk, so I want to hear what other colleagues have to say. Christine Sizemore, please.
Yes, thank you very much. And it was a great presentation. I had one question about your comment on, not calling out, for instance, in the science, in the context of what you provided, that someone is a Black institution or a non-white, but that is in stark contrast to what is happening in the whole context of diversity and inclusiveness, where often it is specifically called out who marginalized populations are. So how can you do both? On one hand, not saying it is a Black organization or a Black university, but in the US context, again, it's exact opposite happens. How do you reconcile?
Well, that's a really excellent question. I don't know if I have any answers here, Christine, but one of the things that helped me understand the connection between these issues around ethnicity, diversity, inclusion for people, as opposed to similar sorts of issues, but for organizations, is this idea of racialized organizations that Victor Ray talks about. It makes that connection because the roots are the same. They're all rooted in sort of coloniality and whiteness and being the norm. But just instead of for people, it's for organizations. I think, his paper only came out a few years ago. I think we need to start thinking about these as from a cognitive justice point of view. So we talk about EDI from a social justice point of view, because it's about people treating other people. But from a cognitive justice point of view, it's about how do we view other organizations. And I think using this sort of language and terminology is actually, I think, helpful. Because it surfaces those tensions and makes us think carefully about how we view those organizations. But I don't know if that answers your question. I'm afraid I don't have any sort of...
Yeah, no, it did definitely help me figure out how to approach it. Thank you.
Great, thank you so much. So apologies if I mispronounce your name, Regine Duta.
Yes, thank you very much. Actually, you did a great job. So thank you, Dr. Harris, for very interesting and informative presentations. I have a couple of questions. So what do you think would be the best, that's the first one, the best approach for developing technology capacity for biomedical research in the Global South, based on what you presented today? And secondly, what's in it for the developed countries to actually, go through decolonization of global health? What's in it for them? Why would they go along and do it? I know it's a it's a loaded question, but we'll appreciate your response.
Okay, thanks, Regine. It's really important questions. I'm going to struggle to answer your first one because I think, investing in settings to improve the capacity around biomedical research is a huge issue. I mean, we're already doing it. I think it's a lot, and I think it's important to do it really safely for that country. There are ways of doing that acknowledges their expertise and doing it in a joint partnership kind of way, which reciprocal innovation I think talks to a lot. So I think that's a huge area that we could certainly get into. To your other question, I think look, there's an ethical and moral reason why we should be doing this. As I hope I explained, at least from my point of view, I think we have structurally ignored the ingenuity, wisdom, and learning and technical expertise from whole regions of the world for far too long. Now, that's bad for a number of reasons. It means that we're missing opportunities to just do better healthcare in our own countries, right? Because there are lots of things that we could be adopting and learning from that actually have equal, if not improved outcomes, but at far lower costs. So whilst it might not have direct patient impact on patient care in each specific example, because they're sort of equivalent, they're non-inferior technologies, the savings can be redistributed across the system, right? So here in the UK, we're constantly moaning and whining about how the system doesn't have enough money, and meanwhile, nurses are dropping out of the system, and GPs can't cope and burning out, and everybody thinks it comes down to more investment in the system. We're not really thinking carefully about how do we use our resources more wisely, right? So I think there's that benefit from a purely self-interest point of view as a high-income country, navel gazer within the NHS, right? But I think it's also important for low-income countries, forgive the stereotypes and the arbitrary delineations here, but we need to acknowledge and raise what Eugene Richardson calls the epistemological currency of the knowledge that they have, advocating for it, shining a light on it and promoting it. But not in a, what's the word I'm looking for? You don't want it to be extractive, yeah? It needs to benefit the low-income country partners if that's where their knowledge has come from. And that's why it concerns me that things like the Saïba's device, the Saïba method, just got, made invisible in terms of the credit given unthinkingly. But we need to be more purposeful, I think, and deliberate about actually learning from settings that we don't traditionally learn from, and actually acknowledging them and even financially benefiting them if necessary through recouping the savings that we've made in our system. So the business models don't exist for that yet. Some of the work that Annette and I have been thinking about is, well, how do you ethically and legally construct a business model whereby the partners in a low-income country stand to benefit from your utilization of their intellectual property, but which is very rarely patented? How do you deal with that, right? So those are all open questions. I don't think we have the answer to that yet, but I think there is, at the very least, a moral imperative for us to address the skews in knowledge distribution around the world.
Excellent. Thanks so much. Amit, please.
Yeah, thank you so much. Really interesting presentation. And I think you've kind of touched on my question already, but I'm curious if you could talk more about, the terminology we use in global health around groups of countries and how that kind of perpetuates this us versus them, high income country versus middle income country, global north, global south, developing, developed. Do you have any thoughts on how we can better describe, groups of countries where different innovations come from without having that, dichotomy coming up so much?
That's a really, really excellent question. I do talk about this in my book, actually, because it's very hard to get out of. In fact, I think one of the first quotes that I mentioned in the book is from Hans Rosling, who talks about our human need to dichotomize and create categories. It makes things easier: black, white, yes, no, male, female. these aren't ontological categories, but we need them to understand the world better and create systems around that. And yes, in global health, there's no satisfying way of categorizing countries. One of my chapters talks about all the different pros and cons of different types of categorizations. Khan wrote about it in BMJ Global Health recently, Len Chuka as well. But they do propose, actually, why not talk about countries as formerly colonized, or countries that are based on extractive capitalism, as ways to describe countries, for example. It's very important also to think clearly about, well, does that categorization have any meaningful connection to the phenomenon that you're discussing? There's no point talking about, I suppose, high-income countries if the income-ness of that country isn't relevant to what we're talking about. I genuinely struggle with the issue, because when we talk about these issues, you somehow have to categorize to some extent, but I try to surface the assumptions in doing so, and also acknowledge that countries aren't only categorized by their income level. Some countries, of course, have rich areas and poor areas even within them, and the US is a case in point.
Great, thanks. Next up, actually, because they had already typed a question, Vidya Vedham, please.
Thanks. Can you hear me okay? Yeah, okay,
yeah.
Perfect. Matthew, I'm not sure I quite understood. First of all, thanks for the great presentation. I'm not sure I quite understood the use with caution idea for using the term reverse innovation. For me, at least from the vantage point I sit in, I don't see that there is a need to use that term at all. But I'm curious what your thoughts are in terms of where that would be the right fit. And while really fascinating presentation, and I'm intrigued by all of the references in your talk. One thing I was curious is you did talk about Victor Ray's work, which is another great body of work to cite. I'm curious why, playing the devil's advocate, how you didn't mention someone like Gurminder Bhambra's work from the University of Sussex, which has published several books on decolonization and thinking about the impact of colonization in modern medicine, and including other areas of academic work and our societal justice as well. So I'm curious. I'll let you answer. Thanks again.
Yeah, thanks. I mean, if you get the book, you'll see that there are many references to that body of work, and many others around the world, Edward Said and many others, right? So I'm limited, unfortunately, by also the time, and I hope by my choices I haven't given a misrepresentation of what I think is relevant. That's clearly not my intention. I think reverse innovation it's actually a term that was co-opted from the management literature, actually, Vijay. So in many respects, it's been co-opted in an incorrect manner, right? So it makes sense when you're General Electric, that first example I gave you, to call it reverse innovation, because it's reversed from a subsidiary of its own organization, But it's, I think, carelessly been applied to the idea of reversing from a low-income country to a high-income country in the context of healthcare research and health policy. We've somehow focused, I don't know when that happened, but we somehow focused on that feature being what constitutes reverse innovation. But actually, GE is applying the terminology reverse innovation to the phenomenon of taking an innovation from a subsidiary, peripheral, to its headquarters, so to speak, in its sort of main country, which is the US. So that term has sort of been co-opted by sort of the health research space, and it's not a neat thing to do at all, because of course many organizations are involved in reverse innovation when we talk about it in these sorts of circles. It's not a management strategy for an international corporation. It's a phenomenon that we've used loosely to describe learning from a low-income country. So I agree with you. There is no right time to use the word reverse innovation in this setting. We published on that point in the series Reverse Innovation in Globalization and Health. But I think as a reflexive moment to understand the general dynamics around learning from some countries more than others, it's a case in point that I think is useful conversation starter.
Excellent. I'm mindful of time, and I've got 3 more people on the list. I would suggest that we, take one more question, and then for those who are still willing, and Matthew, if you still have time to stick around, we will listen to your answers to the other 2 questions. So with that in mind, Larissa Aviles Santa.
Yes, thank you so much. And my question is about language. And first of all, thank you for the wonderful presentation. I'm speaking more specifically about Latin America, that in the map that you showed was a very, very skinny part of the world in terms of the publications and the use of the information. I wonder if in the discussions about decolonization, if there have been any conversations about the role of journals in publishing research findings, and specifically journals being more open to publish in other languages than English. And for Latin America, this has been a major challenge because they have to translate, and English is not the main language as we know, but they tend to publish more in their either Spanish or Portuguese or even French. But when they submit papers for publication, they are required to be in English, and that takes more resources to make sure that the translations are well, etc. So I wonder if this has been brought up, if this could be another strategy for journals that are wide known to allow other languages. Otherwise, the science stays in these countries, because it's not that they are not developing science, they are publishing, but they are publishing locally.
Yeah,
Thank you.
No, you're very welcome. That's an excellent point. So I tried to touch on that a little bit at the end about that journal, Decolonial Subversions, which is publishes in any language. You can submit rather in any language, but I haven't seen many other examples of that. And there's really isn't a good reason for that, I don't think, with all of the sort of machine learning tools around translation and everything else. It really ought to be the next opportunity. Some things are changing in academic publishing, you may already be aware of. For example, editorial boards tending to be a bit more diverse now. Now, whether or not that translates into actual changes in submission rates and acceptance rates remains to be seen. It could be another form of sort of laundering, that we call it, in terms of doing things that look like we're doing it without actually doing it. Another really interesting phenomenon is called, I think it's called northern ventriloquism, which is something I actually experience it all the time, where colleagues from the Global South, I have many colleagues in Brazil, they ask me to help them with their paper, honestly, just because they had struggling with the language. But what they're trying to do, therefore, is to fit in to a mainstream, rather than actually challenging the rules of that mainstream system. It's uncomfortable, actually. So I think there are some developments that are happening that are interesting. I think there are new and innovative, routes that we can go down. But at the moment, unfortunately, I think we just have to be more purposeful in identifying knowledges that are actually just not in English at the very least, but also purposeful in identifying knowledges from regions, even when they are in English, but from regions that we tend to just not pay attention to.
Excellent. Thanks so much. Jessica, would you like to ask your question, Jessica?
Sure. I may have some audio issues. I'm connected to so many different devices that I'm not sure where the audio is actually going.
It's working well.
Yeah. So Matthew, in one of your later slides, you talked a little bit about biomedical hegemony and its relationship with colonialism. And I have a bit of a background. I'm a medical anthropologist and have a bit of a background in traditional medicine and traditional healthcare systems. So my question was, how can we avoid reproducing biomedical hegemony when it comes to reciprocal innovation framings?
Well, it's such a good question, Jessica. I think it's about being intentional, isn't it? Right from the very beginning, when you're constructing your partnerships with other countries, about thinking who sets the agenda, what is it you're going to be exploring, what's important to who has a seat at the table, and taking an interdisciplinary approach in all things. So there's a place for traditional healers, alternative health, allied healthcare professionals. Have a look at who's around the table making the decisions. If it's all surgeons and clinicians and so on, then there's a limit, isn't there, to the amount of new knowledge that's going to be shared. So I think I'm seeing some signs that that's happening in some areas. Actually, I don't know everything that's happening in the world, but I was recently in Côte d'Ivoire at a conference in Abidjan that was specifically about the African contributions to global health, and I was blown away at the extent to the interdisciplinary nature of what was being presented there. So we had architects that were doing epidemiology, right? And epidemiological studies looking at how housing design impacts on health outcomes for populations living in sort of rural slums or urban slums and so on. The real interdisciplinary takes, traditional methods used in Nigeria for safe motherhood, leveraging entire communities to ensure safe delivery in the antenatal period, including traditional healers and alternative therapies as a preeminent sort of knowledge coming out from that region, and elevated and being looked at and considered in exactly the same light as a randomized controlled trial. So it was a fascinating interdisciplinary approach. I think just being open-minded, isn't it? Just comes down to that, challenging and questioning, being alert to when certain people around the table, certain people's voices are being heard and not others, so that you can be as inclusive as possible. It can only be a good thing.
Great, thanks. I should say I need to personally log off in like 7 minutes. But I see that Debbie Vitalis is still on the line, so if you would like to ask your question. And then James Alaro also had a question. So if I need to log off earlier, Matthew, we will communicate via email. But I would love to hear the questions too. So if we can keep it short, that would be great. Thanks. Debbie, please.
Hi, thank you again, Dr. Harris. Mine was not a question, just a comment as well. I worked in the Caribbean region, Guyana in particular, which is very near Brazil, and that whole region has utilizes community health workers, pretty much as the backbone of the healthcare system. So that's just what I wanted to share. And another region that is largely ignored as well in terms of our research and outreach, etc. Thanks.
Yeah, thanks very much, Debbie. Noted. I hear your frustration. As a Brazilian doctor, I was frustrated that no one was paying attention to what was going on in Brazil. Like, I'm sure it's the same in many other countries too. It's interesting, a piece came out from Australia, actually, colleagues, I think a year ago, talking about how when it comes to community health workers, their deployment somehow is different when you look at high-income countries to low-income countries. Somehow they can be the backbone in countries from the global south. But Desiree, if you don't mind turning your audio off, that'd be great. But whereas in richer countries, let's say, they somehow are a nice to have, they're an add-on, they're a parallel system. They're somehow not deployed in the same sort of way. So I think there's a really interesting comparisons there to address.
Yeah, so true. Thank you.
Great, thanks so much. James Alaro, please.
Yeah, thanks for the really great perspective from you. And just following up on your idea of how to achieve truly deep change in the system, and your comment about having to have everybody represented on the table. I wonder what your perspectives are, because that table, especially the table around discussing decolonizing anything, is set by the system that actually generated the colonization. And I wonder to what extent the other side is represented on that table, who decides the agenda that is set. And even these discussions that we're having, I doubt that they involve at a deeper level the other side that actually really needs to be on that table. So I wonder what your perspectives are.
Look, James, it's a fantastic point. Such a complex one to end on. But my book, I reflect a lot on that. Look, I'm a white middle-aged male that's been trained in some of the most elite institutions in the global north. Who am I to be talking at all about decolonization? So I'm very clear in my framing that I'm doing this out of frustration as a global North UK actor, that we're missing lots of opportunities to learn. It's unfair, it's morally corrupt, and we need to do something about it internally within the UK. And if other countries, that resonates with them too, that's terrific. But I'm talking to a UK audience here. Whereas my good colleague, Professor Dhananjay Sharma from Jabalpur, India, just published a piece yesterday in BMJ Global Health talking about how actually decolonization can only happen really from the global south. They need to change the rules of the game. I think sometimes there's a complicitness in the dynamic that needs to be addressed. It goes in both directions. Sometimes researchers from the global south also feel subservient, and they don't have a right to do that. They need to not do that. We need to not allow that to happen. But it has to come from them too. Walter Mignolo actually describes how you can't decolonize because the very question is a colonial question. You only know about the idea of decolonization because of all the knowledge structures that have led you to understand it as such. So you can't actually get away from that. Because as soon as you start to decolonize, you start thinking about funding and partnerships and people and organizations, and we're all part of the colonial apparatus. So it's really, really difficult to do properly and fully. But we can start by, like we're doing now, talking and surfacing and hidden assumptions that are lazy, but that are somehow taken for granted, so that we can begin to do something about them.
Great question and great answer to end on. And you can see, Matthew, there's still lots of people here who are listening, even though we're well beyond time. So thank you so much again for taking the time to speak to us. I wish we could have all met you in person. So we will maybe need to plan for a repeat. And yeah, thank you. I think everybody has the information about the book, so please feel encouraged and invited to check that out. And I also received some questions about your willingness to distribute the slides to the people who participate in the call. Would you be happy for that to happen?
Yeah, absolutely. Great. You have a copy of them, Annette. I think there were so many minor changes, so feel free to distribute those. There's no problem.
Perfect. I will convert them as PDF and circulate them. Thank you so much again, Matthew. Safe travels back home later today. And yeah, we will be in touch.
Thank you so much for the opportunity. I really enjoyed it. Take care.
Yeah, and thanks everyone for joining. Bye.
Bye-bye.